Okay, good morning, everyone. Welcome to our weekly Grand Rounds. It's already February. It's hard to believe. We have a visiting professor today, and I'll offer the stage to Dr. Bakshi to do the introduction for us this morning.
So it is my honor and privilege to introduce Dr. Michael Puente, who's an assistant professor of ophthalmology at the University of Colorado School of Medicine, which means that it is very early in the morning for him right now. And so we're, extra grateful for him being here with us today. He practices pediatric ophthalmology at the Children's Hospital of Colorado. He earned his medical degree at the Baylor College of Medicine and completed his ophthalmology residency at Tulane University and his fellowship at the University of Colorado. His clinical and research interests include ocular disease and Down syndrome, eye care for adults with intellectual and developmental disabilities, pediatric keratoconus, and pediatric cataracts. However, today his topic, although he's an expert in pediatric ophthalmology, his topic today is really related to his incredible advocacy work. He is the co-founder of the American Academy of Ophthalmology's LGBTQ+ interest group and was advocated for their Secretariat Award for advocacy in his work leading a campaign to allow LGBTQ+ people to donate their corneas in the United States. He also serves as the president of the Colorado Society of Eye Physicians and Surgeons and the chair of the legislative committee for the American Association of Pediatric Ophthalmology and Strabismus. And we're really excited to hear today about his amazing work in trying to create equity and inclusion in ophthalmology. So thank you so much for being here today, and I'm really excited to hear your talk.
Well, thank you so much for having me. Let me pull up my slides here. Okay. All right, well, good morning, everyone. It's a pleasure to get to speak with you all today. I'm going to be talking to you about LGBTQ2S+ issues in ophthalmology and ways that we can work towards equity. So I have no relevant financial disclosures. I wanted to start off just by sharing a couple emails that I've received recently. So I got one from a medical student not too long ago. He said, "Hello, Dr. Puente. I hope this message finds you well. I'm a third-year medical student at somewhere. I'm considering applying to the University of Colorado's ophthalmology program, and I wanted to reach out to you to hear your thoughts on how you feel the culture is being an LGBTQ provider in Colorado. I'd appreciate any insight you could offer. Thank you for your time." Shortly after receiving that email, I got another email. This one said, "Dear Dr. Puente, apologies for getting in touch rather out of the blue. I'm one of the ophthalmology residents at somewhere, and I'm currently visiting Denver for ARVO. I'm considering applying for fellowship training here in Colorado. I was wondering if you might have a moment over the next few days to talk to me about your experience here in Colorado, as I saw you were an AAO LGBTQ+ rep." Both of these emails were from potential trainees who were considering joining us at the University of Colorado, but they were concerned that their LGBTQ+ identity might be an obstacle, might in some way make them feel less welcome, less safe at this new institution they were considering going to. And so they reached out to me as an openly LGBTQ+ faculty member to gauge whether they would be safe there themselves. The fact that these trainees felt that these emails were necessary, I think illustrates that we have some work to do in making sure that LGBTQ+ people in medicine feel welcome and safe wherever they are. And we have a lot of work to do in ophthalmology in particular. There was a study that was published in a journal of JAMA in 2021, where they surveyed medical students and asked them what their intended specialty was that they wanted to go into. And they broke it down, ranking specialty preference for students who identified as members of a sexual minority. And guess where ophthalmology fell? We were 22nd place out of 23 in terms of the preference of LGBTQ plus medical students in the United States, ahead of only orthopedic surgery. When you break it down to female medical students who identify as LGBTQ plus, we were again 22nd out of 23 in the United States. And for male LGBTQ plus medical students, we were a little better, 19th place out of 23. But this shows that our field is perceived as perhaps not being as good of a fit for LGBTQ medical students. And there are so many talented LGBTQ plus people out there who could contribute so much to ophthalmology. And I would love to see this number rise much higher so that we can attract a lot more of those very talented people into our field. So with that context, our learning objectives for today are to establish a baseline working knowledge of key concepts related to gender identity, gender expression, sexual orientation, examine the status of health equity for LGBTQ2S+ patients and professional equity for LGBTQ2S+ ophthalmologists, create safe spaces for the LGBTQ2S+ community in both our clinical and professional settings, and foster allyship with the LGBTQ2S+ community in ophthalmology. So I wanted to start off just with some definitions and key concepts. There are lots of different terms and words that you might hear related to the concept of LGBTQ2S+, and some of those words can be a little confusing. So I wanted to make sure that we start off with a shared vocabulary. So the idea of sex is the biological gender that someone is assigned at birth, traditionally male, female, and that's based on external characteristics and sex organs. But about 1.7% of people are born with an intersex trait, and their assigned sex at birth could be changed through medical transition. And this is different from the concept of gender. Traditionally, the idea of gender is someone's internal knowledge based on socially constructed characteristics of women, men, boys, or girls. It includes the norms, behaviors, and roles that are associated with being a woman, a man, a girl, or a boy, and their relationships with one another. But nowadays, that definition has evolved. It no longer defines gender in a strictly binary means where you are either male or female. Some people may feel that their gender identity does not fit neatly into two binary genders. One's concept of their gender usually develops by about age 3 and doesn't tend to change throughout their lifetime. And gender is not necessarily congruent with the sex that you are assigned at birth. There are a lot of gender-associated terms. Cisgender refers to a person whose gender identity aligns with the sex that was assigned to them at birth, whereas transgender refers to a person whose gender identity is different from the sex that they were assigned at birth. And some people may identify as non-binary. So that's someone who may identify with both male or female genders or even neither male or female genders. And this is different from sexual orientation. So that's how a person identifies their physical, emotional, and romantic attachment to others. So like what kinds of partners do you have? An individual's sexual orientation is independent of their sex or their gender identity. And there are lots of different terms for different categories of sexual orientation. Someone may be considered asexual, and that's someone who has complete or partial lack of sexual attraction or lack of interest in sexual activity with others. A bisexual person is someone who is attracted to more than one sex, gender, or gender identity. And it may not be simultaneously, may not be in the same way, may not be in the same degree. Gay is a term that is used to describe people who are emotionally, romantically, or sexually attracted to the same gender. And that's a term that can be used by men, women, or non-binary people. Lesbian is a term that's generally used only to refer to women who are emotionally, romantically, or sexually attracted to other women. And then heterosexual or straight would be a person who identifies as male or female and is attracted to people of the opposite gender or sex. Another term that's important to be familiar with is Two-Spirit. This is a First Nations or Native American term that refers to Indigenous people who fill community roles outside of a gender binary. There's a quote that Two-Spirit people have both a male and female spirit within them and are blessed by their creator to see life through the eyes of both genders. It's a concept that's existed in over 150 tribes in North America, predating European colonization, and it doesn't simply refer to LGBTQ plus Indigenous people. My partner has a lot of Indigenous relatives, and he identifies as Two-Spirit himself here in the United States. So this is something that we don't hear about as often as many of those other terms, but it's an important concept to be familiar with. LGBTQ2S+. So all of those letters there refer to lesbian, gay, bisexual, transgender, queer questioning, two-spirit, with a plus sign to recognize the limitless sexual orientations and gender identities used by members of our community. And queer is a term that can express a whole spectrum of identities and orientations that are different from the mainstream heterosexual binary norm. Previously, it was considered a slur, but now it's a term that has been kind of reclaimed, readopted by the LGBTQ2S+ community. And then questioning is another word from the Q of LGBTQ2S+, that's used to describe people who are in the process of exploring their sexual orientation or gender identity. Almost every LGBTQ2S+ person goes through a period of self-discovery and questioning to try to figure out who they are and what their identity is. It's not something that everyone necessarily recognizes from early on in childhood. So there are a lot of intersections of LGBTQ2S+ identities and medicine. We know that there are a lot of domains of social and health disparities faced by LGBTQ2S+ people in society. There are lots of issues in the legal system where LGBTQ2S+ people may not be treated equally as the rest of our society. There are lots of public policies and structural stigmas that can make LGBTQ2S+ people have different experiences in our society. There are issues with community and civic engagement faced by members of our community. Certainly, there are challenges that we can face in our relationships with our families and social networks. Issues that can be faced in the education setting, economic disparities, and then, of course, physical and mental health disparities, as well as disparities in healthcare access. And medicine historically has played a role in some of the stigma that's faced by LGBTQ2S+ people. Historically, there's been a failure to accept the natural occurrence of gender diversity in the field of medicine. And an example of that is that back in the day, a lot of babies who were born with intersex traits underwent surgery against their will in childhood to make their bodies fit a gender binary. The field of medicine has historically perceived gender diversity as a deviant concept. The DSM included a diagnosis of gender identity disorder until as recently as 2013. Similarly, the field of medicine has perceived same-sex sexual behavior as deviant and included a diagnosis of homosexuality as a mental disorder until as recently as 1973. The field of medicine has also participated in reparative therapies. The American Medical Association first opposed the practice of conversion therapy in 1994, and California became the first state in the United States to sign a ban on that practice only as recently as 2012. And then there are many healthcare policies that discriminate against LGBTQ2S+ people. Within ophthalmology specifically, there's a policy in the United States where any man who has had sex with another man in the preceding 5 years is automatically ineligible to donate his corneas. And that's something I'll be talking about a little bit later on in this talk. So health disparities are something that we have to consider in a minority stress framework. So people who are members of any form of minority will often face stigma-related stressors from external stigmas that are imposed upon them by their external environment. There are general psychological processes that can cause minorities to feel stress from these stigmas, as well as some internal stressors that we can feel. And all of this can lead to some behavioral health problems, which can then convert into physical health problems. So there are a lot of health disparities that are faced by the LGBTQ2S+ community. We're less likely to have health insurance than the population at large. more likely to report unmet health needs, less likely to have a primary care physician. Older LGBTQ2S+ people are more likely to rate their health as poor. Older LGBTQ2S+ people are also less likely to have social support and twice as likely to live alone, both of which have been found to lead to worse health outcomes for older patients. Lesbian and bisexual people have higher rates of obesity. The LGBTQ2S+ population has much higher rates of depression, higher rates of anxiety, higher rates of cervical and breast cancer, while simultaneously having lower rates of pap smears and breast cancer screenings. And then a lot of these disparities can also have intersectional components, where someone who may be LGBTQ2S+ may also be someone from a religious or an ethnic minority group facing additional health disparities and additional stigma on top of their LGBTQ2S+ identity. And transgender people within the LGBTQ2S+ community face disproportionately high levels of health disparities. So what about within ophthalmology? We really don't know. There have been studies in almost every field of medicine looking for health disparities faced by the LGBTQ2S+ community, but our specialty really hasn't done the work to look for those disparities. If you look on PubMed or Google Scholar for papers about health disparities faced by the LGBTQ2S+ community in eye care, there's barely anything. But almost everywhere that we've looked elsewhere in medicine, we've found that there are disparities. And so just because we don't have papers documenting that such disparities exist in ophthalmology, I don't think that that's evidence that those disparities don't exist. I think it's just evidence that we haven't been looking for them. So there's a lot of work to do there. The healthcare experience for members of the LGBTQ2S+ community is often different from the experience faced by the population at large. There was a study of almost 5,000 LGBTQ2S+ Americans done 15 years ago by a group called Lambda Legal, and they found that 56% of LGBTQ2S+ people in their survey had reported having felt discriminated against by a healthcare professional. And their survey found that rates of having felt discriminated against by a healthcare professional were particularly high for transgender Americans and for LGBTQ2S+ people living with HIV. So intersectionality, like I mentioned before, that describes how individuals with multiple marginalized identities can experience multiple and unique forms of discrimination that can't necessarily be conceptualized separately. So for example, a gay man has to deal with homophobia, a Black man has to deal with racism, but a Black gay man would have to deal with both homophobia and racism often at the same time. And those two combined forms of stigma often exacerbate the effects of each other. Similarly, a disabled lesbian Muslim immigrant may have to deal with ableism, homophobia, Islamophobia, racism, and sexism all at the same time. LGBTQ2S+ people also have higher rates of poverty than the population at large. And we all know that patients in poverty face many healthcare disparities. It's harder for them to access care in the United States, where our healthcare system is less equitable than in many other Western countries. It can lead to inability to pay for medical care, to pay for necessary medications. And so this is likely a big factor in some of the healthcare disparities faced by LGBTQ2S+ people. There are also a lot of stressors faced by LGBTQ2S+ physicians. So lesbian, gay, and bisexual medical students are about 8 times more likely to report burnout or facing discrimination compared to their peers. We face increased rates of depression and anxiety, perceived discrimination, harassment, and social ostracization. Many LGBTQ2S+ trainees and physicians choose not to disclose their sexual orientation at all to their colleagues and supervisors because they fear that it may hurt them. They may feel uncomfortable discussing their partner with other attendings or bringing their significant other to departmental events, which is just an extra stressor that's not faced by heterosexual cisgender peers. For example, when I was a resident doing my residency in Louisiana, which is a very red state in Louisiana, in the United States, I didn't come out as gay professionally until my graduation day, once I had my diploma in hand, because I was concerned that if my attendings knew that I was gay, that it would hurt me, that they would treat me differently, that I may be deprived of learning opportunities that other residents were offered. And whether I was justified in that fear or not, it was something that I had to deal with for 4 years. That I was concerned from many other experiences I had had throughout my life, that if my teachers in residency knew that I was gay, that I was worried it was going to hurt me. A higher percentage of LGBTQ2S plus MD PhD trainees report sexual harassment as a barrier to career advancement compared to their non-LGBTQ2S plus peers. So there are a lot of stressors that ophthalmologists themselves can face if they're LGBTQ plus. There's also the concept of implicit bias that's important for us to understand. So thoughts and feelings are implicit if we are unaware of them or mistaken about their nature. And we have a bias when, rather than being neutral, we have a preference for, or conversely, an aversion to a particular person or group of people. And implicit bias is when you may have attitudes towards people or certain stereotypes without your conscious knowledge of that. And there are lots of different ways that implicit bias can manifest. And one of the most common ways is through something called microaggressions. So those are everyday, subtle, often unintentional interactions or behaviors that communicate a form of bias towards a historically marginalized group. The difference between a microaggression and overt discrimination or a macroaggression is that the people who are committing a microaggression might not even be aware that they're doing that. And there are three main forms. That's micro-assault, micro-insults, and micro-invalidations. Micro-assault would be things like physical manifestations of implicit bias, like avoidant behavior. If you have an implicit bias against transgender people, and your transgender colleague is sitting in the physician workroom, and you decide you're not going to go sit in that workroom and do your work there. You're just going to stay in the exam lane and sign your notes there. That type of avoidant behavior, even if it's something that you're only doing subconsciously, is considered a microaggression, microassault. Or moving away, keeping a certain amount of distance because you don't want to be too close to the LGBTQ2S plus person. There can also be overt negative representations of LGBTQ2S plus people in the media. Queer women are sometimes considered as sex objects for heterosexual men. And there are people who perceive bisexuals as being either fickle or not even existing. Things like that would be considered micro assaults. And then micro insults are just small comments that convey a form of bias against LGBTQ2S plus people. Comments like, you don't sound or look gay, which imply that you have a certain idea of what it means to be gay and that this person's identity does not fit into your definition. Being bisexual is greedy. You just want the best of both worlds. It's like, how did you turn gay? Aren't you making your life hard for yourself? Which one of you is the guy in the relationship? Do I have to worry about you fancying me now? Comments like this that may seem harmless or even like a joke are things that can add to the daily stress faced by LGBTQ2S plus people. And then there are other comments that could be considered micro invalidations, where you dismiss the feelings or experience of an LGBTQ2S plus person. Things like saying you're being oversensitive, You're just confused. It's just a phase you're going through. Why are you making things so hard for yourself? Why do you have to flaunt it? I'm okay with you being gay, but you don't have to be so obvious about it. I'm not homophobic, but you can do what you want, but I don't approve of it. How can you be queer if you've never had a sex with a member of the if you've never had sex with a member of the same sex? Just little comments like this that can portray that you are less respectful or dismissive of the experience faced by LGBTQ2S+ people. And a lot of these comments can be pretty easy to make. So LGBTQ2S+ people face many unique forms of discrimination that can take many forms. And as a result, LGBTQ2S+ people are subject to minority stress, which can affect their socioeconomic and health status. And people with intersexual identities are particularly prone to bias and its negative effects. So, taking all of that into consideration, it's really important for us to create safe spaces for the LGBTQ2S+ community. And there are lots of ways that we can do that. But a safe space refers to a physical or metaphorical place for people, usually of marginalized identities, to feel free of judgment or harm. And it can take many forms. There are safe spaces specifically for members of the Black community or of the Hispanic or Latino community or the LGBTQ2S+ community. Here in the healthcare system in the United States, we have entire hospitals that are dedicated for caring for military veterans who are themselves a marginalized community. And those hospitals, called our VA hospitals or Veterans Affairs hospitals, they are designed taking everything into consideration to make it the safest, most welcoming place for that specific marginalized community of former military members. And it's something that almost every ophthalmology trainee in the United States has some experience training in. So we all get the experience of practicing in a place that is designed to be a safe space. And so it's important for us to make sure that our ophthalmology practices are safe spaces for the LGBTQ2S+ community. And that's important for a lot of reasons. LGBTQ2S+ people, they want healthcare and work environments where they feel welcome and respected, just like anyone else would. But the history of stigma faced by almost every LGBTQ2S+ person may make them wary of facing bias in healthcare or employment. And feeling validated can make people more engaged in their healthcare and their work. If you have an LGBTQ2S+ patient who feels that you're not treating them, who feels that you're treating them differently because of their LGBTQ2S+ identity, they're going to be less likely, I would suspect, of being compliant with your treatment recommendations. Whereas if you make them feel more welcome, more seen, you're going to develop a better therapeutic relationship with that patient, and that's better for their health. So ophthalmologists should strive to create a welcoming environment for all LGBTQ2S+ patients and staff. Language is a big part of that. Our word choice can make a strong impression on LGBTQ2S+ people. But LGBTQ2S+ identities don't always conform to common linguistic elements. Some language that we use could inadvertently make LGBTQ2S+ people feel unwelcome. So there are some examples that I've found in my clinic. I had a patient a couple years ago who had two moms. And when I told those moms that I'm gay myself and that they were in a safe place, they just started venting about all these negative experiences they had had in other clinics. The one that bothered them the most was that a doctor had once asked them, "So who's the real mom?" Um, that doctor presumably was trying to better understand the child's genetic risk factors for certain diseases, but asking who's the real mom is not a tactful way of getting that information. It made them feel very unwelcome. It made them feel very invalidated. That they're both equally that child's mom, and that doctor could have much more easily asked that question in a way that that could have made the family feel safer. Similarly, in particular in pediatric ophthalmology, I have a very large percentage of my patients who identify as non-binary. And I try to always make sure that I do my best to use a patient's preferred pronouns. And patients definitely notice that. I had a family leave a review on our website saying that I was helpful and knowledgeable, but they really appreciated the effort that I made to use gender neutral pronouns. That was something that was important to them. I think that they probably noticed that a lot of other doctors taking care of that patient did not necessarily use their preferred pronouns. And so when I did, that was something that they noticed and that they appreciated enough to leave a review saying that that was important to them. There are a lot of potential pitfalls that we could experience with language that we might use in clinic every day. When you first walk into the room, you might be tempted to ask, so what brings you in today, ma'am? But you could just as easily say, what brings you in today, without using a gendered word that may not be appropriate for that patient. You may ask a question like, do you have a wife? Do you have a girlfriend? Do you have a boyfriend? Do you have a husband? You could just ask, do you have a significant other? That's something that I hear very commonly. I'm at an ophthalmology meeting in Texas right now, and there was a meeting in Arizona a couple years ago where someone was actually trying to recruit me to join their practice, and they asked me that question: "Do you have a wife?" While I was wearing an LGBTQ pin, um, and that made me feel like that is definitely not a practice that I want to join. That the person running that practice was making assumptions about me, just assuming I'm a man, so I must obviously be straight. Uh, and that simple question, "Do you have a wife?" Made me feel that that was not a place that I was going to be welcomed and accepted. And then you may ask, like, is there any history of eye disease in your mom or your dad's family? Well, some people have two moms, they have two dads. You could just as easily ask, is there any history of eye disease in your family? When we use very specific gendered words with our patients, we're making assumptions about them, we're making assumptions about their families. And for someone where your assumption is wrong, you just made that patient feel some stress. This is something, when I was asked, do I have a wife? Uh, when I get a question like that, I always pause for a moment, and I have to think about, like, is this person who just asked me that question, is this someone who it's safe for me to disclose my LGBTQ2S plus identity to, or is this someone where I need to hide? That's a little bit of extra stress that we have to face. It's just a little thing, but it adds up. Similarly, my partner, he was born in Russia, came to the United States when he was 6 years old, and I have a lot of Russian-speaking patients in my clinic, and I feel like I have something in common with those families. I have Russian in-laws, and I hear Russian on the phone almost every night. I eat Russian food at home, but I feel unsure whether I can disclose that connection that I have with my Russian speaking patients, because I worry that if I tell them that my partner is male, that they're going to feel uncomfortable taking their kid to my clinic, that they may complain about that. And that's something that my heterosexual peers don't have to consider when they're interacting with their patients and their families. So registration forms are something that almost every patient has to fill out when they're first entering your practice or coming to an appointment. And that's a great opportunity for you to demonstrate to patients that your practice is welcoming and safe. But conversely, it could also be an opportunity for you to demonstrate to people that your practice is not welcoming or is not safe. So here's an example registration form, and I'll give you guys a moment to look through here and see if you notice any potential issues. for LGBTQ2S+ patients filling out this form. So there are a few. Obviously, having patients check a box for their sex of just male or female is going to be very uncomfortable for your patients who may not identify as strictly male or female. Making people choose a title of Mr., Mrs., Miss, or Miss could also be could also exclude people who don't identify with those titles. A transgender person may have a preferred name and a legal name if they haven't changed their legal name yet, and just giving them one line where they're supposed to put in their name could be difficult for them to decide what to put there. And then marital status. At least here in the United States, we only got the right to same-sex marriage just a few years ago. And so there are many people in the LGBTQ2S+ community who've been in loving relationships for decades, but who were never able to get married. And just because it's legal now doesn't mean that they necessarily have. So if you force people to choose between single, married, widowed, divorced, you may be forcing people who are in long-standing, loving, committed relationships to not have any idea what they're supposed to circle there. So there are lots of examples of registration forms that are more inclusive and more welcoming for people with LGBTQ2S+ identities. A great example is from an organization called Fenway Health out of Boston. I have no connection with them, but they have a lot of great resources on their website, including a registration form that is very LGBTQ2S+ inclusive. Your physical space in your clinic or in your office can also convey that you are a welcoming practice for people with LGBTQ2S+ identities. So your clinic could have some subtle visual cues that LGBTQ2S+ people are welcome. You could have things like badge holders or lanyards with a pride flag on them. You could have just a very small LGBTQ2S+ flag, maybe behind the checkout desk. If you have magazines in your waiting room, which many ophthalmology practices had before COVID at least, you could have an LGBTQ2S+ magazine just sitting in the stack of many other magazines. You should have a posted non-discrimination policy. And if you have single-use restrooms in your clinic, there's no reason that you need to have a single stall restroom just for men, a single stall restroom just for women. Making those all gender is an easy switch that would be more welcoming for many of your patients. We had a patient file a complaint against my department about a year ago because a dad was very upset that his child was worked up by an obviously gay technician before his eye exam. And a dad filed a complaint with the hospital saying that he thought it was inappropriate that a gay person worked at a children's hospital, that it was trying to stuff some ideology down their throats and impose that on families that don't support LGBTQ+ people. And my boss had a choice to make on how to respond to that complaint. And she felt that it was important for our department to be supportive of its several LGBTQ+ employees and to be supportive of our LGBTQ2S+ patients and families. So she responded to that complaint by buying every single person in our clinic a pride flag lanyard. So having LGBTQ2S+ staff is another important way that you can convey that your practice is welcoming to the LGBTQ2S+ community. They're often spending more time with the patients and the families than you are, and they can do a lot to convey that LGBTQ2S+ people are welcome and safe in your clinic and your practice. Your digital space is another important place where people will interact with your practice. And think about the photos that you have on there. Do you have LGBTQ2S+ people in the photos on your practices or your department's website? If you look at the websites for ophthalmology and optometry practices and optical shops here in the United States, at least, you often see pictures of very happy heterosexual cisgender couples in glasses. But you could just as easily have photos of very happy LGBTQ2S+ people in glasses. That's an easy switch that you could just put a picture here and there on your website, just to convey that you recognize that the people that LGBTQ2S+ people exist, that they're important, that they are welcome in your practice. You can also include your preferred pronouns on your Zoom name, your Zoom title, or in your email signature. And then it's important to have staff training to highlight the importance of being able to interact with LGBTQ2S+ people, patients, and fellow staff. So anyone interacting with patients should be able to deal with LGBTQ2S+ patients respectfully. If the person at your check-in desk or your technician is not trained to deal with this type of patient respectfully, they may inadvertently, due to implicit bias, make some sort of microaggression, microinvalidation, something before you even walk in the room that conveys to the patient that they're not welcome in your practice. So it's important to incorporate LGBTQ2S+ sensitivity in your staff training. And it's important that this comes from the top. There's a temptation, I think, oftentimes to just assign whatever LGBTQ2S+ person works in your clinic as the person who's in charge of implementing this type of training. But that is something that could be considered a minority tax, where it's extra work, it's extra responsibility that's placed on someone because they happen to be a minority, and they may not be compensated or rewarded for that extra work that you put on them just because they happen to be a minority. And then beyond just training your existing staff to be able to interact with LGBTQ2S+ people respectfully, it's important for you to be able to retain and recruit people who happen to be LGBTQ2S+. So your non-discrimination policy should explicitly protect LGBTQ2S+ people. Your benefits package should allow equal benefits for same-sex partners. You could consider advertising your job listing in LGBTQ2S+ publications or media, and mention your non-discrimination policy in that job listing. You could also participate in LGBTQ2S+ events, like pride events or pride parades, to show your clinic or your department's support for LGBTQ2S+ patients and staff. And then for people who are not LGBTQ2S+ people, anyone can be an ally of the LGBTQ2S+ community. So how do you do that? Hopefully you may have picked up a couple tips and tricks from some of the things that I went over in the previous slides. But if you're ever unsure about how to handle something, how to say something, it's okay to ask a member of the LGBTQ2S+ community and convey that you're just trying to learn, that you want to be a better advocate and ally, and if you have any questions, we're always happy to help teach you and share our experience and help you to be a better ally. There are a lot of resources out there, specifically healthcare resources, for people to be allies and to create safe spaces. There are some programs that will have LGBTQ applicant chats. If you have an LGBTQ trainee or member of your department, they could have some sort of webinar or chat, or be available to talk to people who are considering joining your department, so that they can share their experience. There are many faculty learning opportunities available through academic institutions. There are some offered by Stanford, by Harvard, by Cleveland Clinic, and by Fenway Health. And then there are also resources available through our professional societies. So I co-founded an LGBTQ interest group within the American Academy of Ophthalmology a few years ago. And so now there are resources on the AAO website, specifically talking about issues faced by the LGBTQ2S+ community in ophthalmology and ways to advocate for that community. And now we have official events at the AAO annual meeting. We have an annual meet and greet. We did our first one in New Orleans in 2021. And you can see that we had about 15 or so people come to that first one. But we had one this just a few months ago in San Francisco, and we had over 150 people come to our LGBTQ meet and greet at the American Academy of Ophthalmology's annual meeting. So it was something that grew exponentially in a few years and was considered really, really valuable. I had someone I respect, uh, someone that I've learned so much from seeing his presentations on the podiums at AAO and other meetings. And he told me that even though he's been an ophthalmologist for about 15 years, our LGBTQ social was the first time that he felt he could ever be himself, the first time that he ever felt truly welcomed at an ophthalmology meeting. There are also opportunities for mentorship for LGBTQ2S+ trainees through the American Academy of Ophthalmology and through some of our subspecialty societies here in the United States as well. And then there are now some initiatives through Organized Ophthalmology for advocacy. We have a program in the United States called the Minority Ophthalmology Mentoring Program, which helps to recruit members of demographics that are underrepresented in medicine to help them to put together more competitive applications for ophthalmology residency so that we can diversify our workforce and provide better care to patients from those communities. The AAO has a task force on organizational diversity, as well as a task force on disparities in eye care. And then I'll talk for the next few minutes about an organization that I created called Legalize Gay Eyes. So when I was a resident myself, I heard the story of a teenage boy in the state of Iowa. His name was AJ Betts. And shortly after his 16th birthday, he committed suicide because he was being bullied for being gay. He was able to donate his heart, his lungs, his kidneys, his liver. But when his mom asked who received his corneas, she was told that they were never even collected because it was illegal. He was gay. And so she was very bothered by that, and she took that to the press. And I came across that story while I was a resident. That got me, that made me very upset hearing that story. And so I wanted to know if that was true. So I looked up, I went onto the FDA's website, and I found that that was in fact true. On May 20th, 1994, the United States Food and Drug Administration instituted a policy saying that any man who's had sex with another man in the preceding 5 years is automatically ineligible to donate his corneas. For the next few slides, I'll use the letters MSM to abbreviate men who have sex with men. And that policy has been in place for almost 30 years now. And it's a 5-year deferral policy for corneal donation, but that's different from the policy, the exclusionary policy for other potentially high-risk corneal donors. For example, a heterosexual person who's had sex in the last 12, who's had sex with someone known to have HIV is only ineligible to donate their corneas for the first 12 months after that known HIV exposure. People in the healthcare field who've had a needle stick where they were exposed to HIV are only ineligible for 12 months after that exposure. Children who were born to mothers with HIV are only ineligible to donate their corneas for the first 18 months after they leave the womb of an HIV positive mother, or for 12 months after they've been breastfed by an HIV positive mother. And that compares to 5 years for men who have sex with men. And that policy for corneas is different from the policy for other organs or tissues. For example, there is no deferral period whatsoever for MSM donors of hearts, lungs, kidneys, or livers, solid organs in the United States. And the United States recently eliminated its deferral period for MSM blood donors. But meanwhile, we still have the same policy in the United States today that was instituted almost 30 years ago. But any corneal tissue donor undergoes a rigorous screening process to determine if it's safe for them to donate their corneas. That includes a medical history, HIV-1 antibody testing, HIV-2 antibody testing, HIV antigen testing. Even if all of that testing is negative, but the eye bank finds out that the donor was MSM, they're automatically ineligible to donate. And that's despite there being very, very high reliability for the HIV testing that's performed in all corneal donors. So a window period is the amount of time between someone's exposure to a virus and the time that it takes for the test for that virus to be reliable. So for HIV-1 ELISA, that test is reliable as soon as 20 to 25 days after someone's been exposed to HIV. For HIV-2 ELISA, it's also reliable as soon as 20 to 25 days. And nucleic acid testing is reliable if it's performed as soon as 4 to 8 days after someone has been exposed to HIV. That's all much shorter than 5 years. When I was looking into this, I went into our library at the University of Colorado, and I found physical paper journals with case reports of people who received corneal transplants from HIV positive people. And I found at least 10 case reports of people who had received corneas from HIV positive donors, but not a single one of those people ever got HIV. Despite the fact that the people who received solid organ transplants from those same exact donors all got HIV. So that tells us that the risk of HIV transmission from a corneal transplant is very low, even in the case of HIV positive people, because the cornea is not a real reservoir of the HIV virus. So we're turning away a lot of corneas from otherwise eligible MSM donors, and that's in the setting of an enormous global burden of corneal blindness. There was a study that came out in 2016 finding that there are about 12.7 million people in need of corneal transplants around the world, but only 1 cornea is donated for every 70 corneal transplants needed. So there's a huge need for more corneas, and here in the United States, we're turning away a lot of corneas just because of people's sexual orientation. So as a resident, I started thinking about how are we going to change the law? So I turned to the literature to see what other ophthalmologists had to say about this. And when I went on Google Scholar and PubMed trying to find any article in the ophthalmology literature talking about this policy, not a single thing came up when I was a resident myself back in 2019. So I decided that this was something that needed to be looked into and published. So I published an article in 2020 where I put together a team and we called every eye bank in the United States. We also called every eye bank in Canada because Canada has a similar exclusionary policy, a 12-month deferral period for MSM corneal donors. We called every eye bank and we asked them how many corneas they turned away from otherwise eligible donors just because of their sexual orientation. And we estimated that it was anywhere between 1,558 and 3,217 corneas every year that are turned away from otherwise eligible donors in the United States and Canada just because the donor is MSM. And we contacted eye banks all around the world as well to find out what their deferral policies are. And the United States is a huge outlier with a 60-month deferral period for MSM donors. Canada is an outlier itself, having a 12-month deferral period. That's certainly a lot shorter than the United States, but there are many other countries around the world that allow HIV negative men who have sex with men to donate their corneas, no questions asked. So I got to work advocating, trying to get the field of ophthalmology and the field of medicine to take a stand on this policy for the first time since 1994. I introduced something called a council advisory recommendation. That's something that the American Academy of Ophthalmology, it's a process where rank and file ophthalmologists or members of ophthalmology subspecialty societies can introduce a resolution for consideration by the Board of Trustees of the American Academy of Ophthalmology. And I introduced a council advisory recommendation in 2020. asking the Board of Trustees of AAO to take a stand on this policy for the first time. And that policy, that recommendation was adopted. And now AAO has explicitly said that they are in support of evidence-based deferral policies for corneal donors, and they've helped me in advocating directly to the FDA and to the Biden administration to change this policy. I also got the American Medical Association to take a stand on the corneal donation deferral policy for gay men for the first time. And I asked many other medical organizations and got all of them to take a stand on this for the first time and help us in this advocacy push. I also thought it was important to raise public awareness. So I set up a website, legalizegayeyes.org, a couple of years ago, to educate the public, but also to allow them to contact their senator or their representative in the United States Congress, asking them to take a stand on this and to help us to convince the FDA to overturn this policy. And I did a lot of work on social media to raise awareness about this. And we ended up getting a lot of attention in the press, not only here in the United States and Canada, but also in South Africa, in England, and in Australia, talking about our campaign to allow men who have sex with men to donate their corneas. And then all of that helped us to get the attention of the United States Congress. I reached out to my representative here in Colorado, and he invited me to write a letter, which he then circulated across Congress. And we got over 50 members of the United States Congress to sign this letter that I wrote, urging the FDA to overturn this policy. And I got similar letters from leadership of the American Academy of Ophthalmology and the American Medical Association and the Eye Bank Association of America. And we finally got the FDA's response, where they announced at the beginning of last year that they intended to update the policy that bans men who have sex with men from donating their corneas. They said that they were going to do that by the end of 2023, but they haven't done it yet. So actions speak louder than words. The FDA has at least said that they intend to update the policy, but we need to keep some pressure. We're almost there. So in summary, LGBTQ2S+ people face many forms of adversity affecting nearly every aspect of their lives, and health disparities exist for LGBTQ2S+ people throughout the field of medicine. Ophthalmology has a lot of work to do to become a more welcoming space for LGBTQ2S+ patients and providers. And I thank you all for your interest in learning more about this issue.
Well, thank you, Michael, for your talk this morning. And congratulations on your advocacy work. I think that's an incredible amount of work that obviously went into that. And it's nice that you're receiving a successful signal from the FDA. And I hope they do follow through on that. Interesting to see that there's similar policies in place in Canada as well. And you're right, donor tissue is a great limiting step for many countries. So that is great work that you're doing.
Thank you.
I think Myrna Lichter is going to make a comment. I'm just going to bring her on the panel. Go ahead, Nubra.
No, I just wanted to say thank you so much for that incredible talk. And I think it's really staggering to hear some of those statistics of the discrimination that is faced, and also that daily thought and constant encounter of how do you present your whole self in engaging with patients, or patients when engaging with your care provider. And I think that that was really important to hear. And thank you also for sharing your personal experiences with your patients and just your own training as well. I think that that was really powerful. So, Myrna, did you want to say anything?
Oh, Michael, I want to thank you for a wonderful presentation. I've worked actually in two-spirit shelters, and they're an amazing group of people. But, I do have a question about training LGBTQ spirit residents. Now, the problem arises with pronouns, and especially around patients. And I've noticed a certain amount of almost microaggression on the part of residents who have decided they wish to change pronouns. It's often hard, especially with an elderly population, to shift them to accept the pronouns of residents. How do you address this with your LGBTQ residents?
That's a challenge. I think our LGBTQ plus staff who have changed their pronouns, that's something that they deal with, um, unfortunately, constantly. I think it's something that they have to deal with outside of work as well. And I think most of them understand that there are people who um, are hell bent on not uh, accepting this other person's transgender identity. I think it's important for us to show that we support and respect those trainees. You don't want to have hostile interactions with your patients, and so it's hard to correct patients who are using the wrong pronoun to refer to one of our residents. Um, you can, I, I think commiserating with your residents and telling them that you support them, make sure that
Yes, of
you
course.
and all of your team are using the right pronouns is going to make them feel more welcome in their work environment.
Yes, and I also agree that I think times will change and people will progress, but I think that this idea of resentment against people who use the wrong pronoun is very negative. And, I think a gentle way to talk to patients is say, I would prefer you use the pronoun whatever that suits you better, rather than being kind of like there's almost a microaggression against patients who use the wrong pronoun, as if they're doing it deliberately to insult you. They're not always doing that.
Sure.
How many times was I called nurse when I was younger and in training? I mean, should I be offended, or should I just, sort of say, not everybody is as progressive? So just as a thought, and thank you so much for this wonderful, wonderful work.
Also, I'd like to congratulate, first of all, Michael, thank you very much. And Amandeep and Nupra, congratulations. I think this is an important topic that we broach. I have a question. How does it, they say a high tide raises all boats. How does this differ from other forms of discrimination? I mean, should we, if the big picture is discrimination all across the board. We know that, unfortunately, our society, our culture is just filled with that. How do we raise that tide to make it a safer space, regardless of whether you're, LGBTQ2 plus, or as Myrna said, a female who's really a doctor and being called nurse? How do we, or religious or other forms of discrimination, and make a space safe for all?
I've found that as a gay doctor, I feel that I can relate a little bit more with some of my patients who have other marginalized identities, people who come from other underrepresented backgrounds, that all of our experiences are different, but we have some shared obstacles and stressors that we all face. And so I think that creating a diverse work environment, a diverse clinic, will help to foster a culture that is more welcoming for everyone.
Okay, fair enough.
I had one other question, Michael. How do you think, in taking histories, when we're seeing patients, what is the most inclusive way to ask about somebody's, either, the typical question we were taught in medical school, at least I was taught in medical school, is do you have sex with men, women, or both? And the both was supposed to be like the inclusive piece. And I think that is obviously still demonstrating a very binary setup. And what is the best way to ask that? And obviously, we're only trying to get at potential risk factors in terms of higher risk sexual behavior and STD risks. And in my clinic, certainly that comes up because I do uveitis. So what is the most inclusive way to ask these questions?
You can ask more open-ended questions like, are you sexually active, and who are the types of people you're sexually active with?
Yeah, and it's, as you said, it's as simple as that, like changing our paradigm of sir, ma'am, and you know, the kind of simple things that we say. Who's your, you know, who's your spouse or who's your partner, who's your significant other, than who's your husband or wife. I think it's, as you said, thinking, just making that conscious moment to think about it rather than, you know, what we've potentially trained to say as default. And I just wanted to also commend you on your advocacy work, because I know that was like a fast slew of slides, but I can imagine the hundreds and hundreds of hours that it took to get that change and all of those people on board and to really create that. Is your plan to try and make it zero then, like solid tissue donor? Or what are you hoping for from the Academy for, or sorry, from the FDA for corneal tissue? Did they indicate
I
what
think
the new regulation will be?
I think any policy where there's an exclusionary period longer than the window period of available testing would not be evidence-based. So I think if our window period for available testing for nucleic acid testing is 4 to 8 days, I think any policy beyond a 4 to 8 day deferral is not evidence-based.
That's what, that would be wonderful. Certainly the same work is needed in Canada as well. Thank you so much.
Okay, well, Michael, thank you again for making the time and effort to join us. I know it's very early for you, but we appreciate your time, and it's wonderful to learn about the work that you're doing. So thank you. We'll wrap up Grand Rounds for this morning. We'll have to connect at the AUPO. Peter's here as well, so we'll look out for you today.
That'd be great.
All right. Have a good day, everyone.
Thank you.
Thanks,
Bye.
Michael.
Thank you.